with Aran from Shaare Zedek, which is one of our first and major collaborators. Adi is also a pioneer in Israel, in the world, in the field of medical cannabis, and they will talk with us about the placebo effect.
Thank you, Gal, and good afternoon, everyone. So I'm going to talk about mediators of placebo response to cannabinoid treatment in children with autism. So throughout history and until not many years ago, a good doctor was an artist. He was knowledgeable and he was an expert diagnostician. He knew how to listen, how to take a good history, and how to perform a thorough physical examination. Indeed, the treatment was not always amazing. As you can see in this picture, this treatment, the real name of this treatment is hydrotherapy. It was common at the beginning of the 20th century for a variety of neuropsychiatric disorders, from hyperactivity to lethargy. So definitely the treatment is better today, but nevertheless, there are some skills that it is a shame that we are losing, because knowledge is still important, even in the era of databases, and the careful medical history is important even in the era of big data, and a thorough physical examination is important even if the patient is scheduled to have an MRI. And an intelligent integration of all this data, or simply thinking, is important and cannot be replaced by exome sequencing. However, today I would like to talk with you about another important resource that it seems that we are losing in recent years when we are driven to be efficient instead of artists. And I'm talking about one of the most effective, most safe, and most cheap treatments that we have in neuropsychiatry, and I'm referring to placebo. So placebo effect is definitely not a term that related or reserved only to clinical studies. Placebo effect plays a major role in any therapeutic interaction. In some of the most common disorders in neuropsychiatry, such as headaches, depression, anxiety, and sleep disorders, the contribution of placebo to the total effect of the treatment it's the most effective or the most important contributor to the efficacy of the treatment. Most of the effect is placebo. It also works the other way around. If we are not careful with what we say to our patient, we might cause harm. For example, if we will tell our patient, wow, with this brain imaging, it's a miracle that you are still walking, he will probably stop walking. And if we will tell him, this medication, okay, I will give it to you, but it might have many adverse events, he will have many adverse events. It is called a nocebo effect. I think that today one of the most important things that differentiates a good, a senior and experienced physician from a young and less experienced one is not the knowledge, is not the analytic ability, but the ability to harness the placebo effect into the purpose of the treatment and to avoid nocebo effects. We all know that different people vary in their response to medications, in terms of efficacy, in terms of adverse events, but we don't always remember that most of this difference is due to differences in placebo and nocebo effects between people. Of course, placebo effect is also very important in the development of new medications. All of the pharmacological treatments for the core symptoms of autism have been failed placebo-controlled studies in the recent decades. And that's why we don't have currently an effective pharmacological treatment for the core symptoms of autism. Some of these treatments were simply not more effective than placebo. For example, secretin, you can see here that secretin is effective in decreasing the symptoms, but placebo is even more effective. The same is true for intranasal oxytocin. Despite of our high hopes from the hormone of love and friendship, A placebo-controlled study with 290 children demonstrated recently that the treatment is not more effective than placebo. But for other treatments, such as belovaptan, the recent one to fail so far, there was some effect of the treatment over the effect of placebo, but this effect was not statistically significant. So there are many reasons why belovaptan failed the phase 3 studies that were recently completed. But the authors of this paper, which are considered experts in the field, like Evdokia Anagnosto and Eric Hollander, they state that the main reason for the failure of this study is a higher than expected placebo effect. If the placebo effect is relatively high, as you can see in this diagram in purple, then even if the treatment has some specific effect, as you can see here in blue, it will be difficult to prove the difference between the treatments unless we will use a high number of participants. On the other hand, if we will be able to decrease the placebo effect, as you can see here in the right diagram, then it will be much easier to prove the difference between the treatment and the placebo. So to sum up so far, in the clinical setting, we want to increase the total efficacy of the treatment. And to do that, we need to increase, or the easiest and safest way to do that is to increase the effect of placebo. On clinical studies, on the other hand, we want to prove that the drug is more effective than placebo. And in order to do that, we want to decrease the effect of placebo. So how do we do that? How do we play with the effect of placebo? To do that, we need first to understand what are the contributors to placebo effect in our population. So first, it is important to understand the terms placebo effect and placebo response. Placebo effect describe all the psychobiological and psychosocial processes that take place inside our head, inside our brain, and lead to improvement following a placebo treatment. For example, the release of endorphins following a placebo treatment to alleviate pain. And the three main contributors to placebo effect are treatment expectations, the expectations of the participant from the treatment, behavioral conditioning, which means that like Pavlov's dogs, our brain can learn to associate a certain physiological response with a certain non-specific stimuli, like a bell and drooling. The same is true for medications. If, for example, I will take a pink pill, prednisone, my brain will learn to associate the pink pill with the with a suppression of my immune system, and then after a while, if I will take a placebo, red pill or pink pill, my brain will suppress the immune system more than someone who never has taken a prednisone. And the third factor is the quality of the patient-physician relationship. Placebo response, on the other hand, include all the factors that contribute to improvement following a placebo administration, which include, of course, the placebo effect and also regression to the mean, which means that every disorder has its ups and downs, and usually we take medication when the disorder is worse, and then naturally we expect some improvement even regardless of the treatment. A spontaneous remission in disorders that has spontaneous remission, and the Hawthorne effect, the effect of being observed, which means that just by participating in the study, the patient is expected to be better. But this is all true in adults. What about young children or children with disabilities who do not have any expectations from the treatment? And indeed, some people believe that children with disabilities do not have a placebo effect, and of course this is not true, as I demonstrated earlier in all the studies in autism so far, and also our study with cannabinoid treatment in children with autism. And briefly, in this study, 150 participants have been randomized to receive either one of two cannabinoid treatments or placebo for 12 weeks. And then after a 4-week washout, they received another treatment for another 12 weeks. And baseline assessments included EDOS and Vineland, and there were 4 outcome measures, 3 of which assessed the behavioral problems, and 1 assessed the core symptoms of autism. And here you can see a diagram which represents the 3 behavioral assessments, and for each assessment there is a first treatment period and second treatment period, and the green columns represent the ratio of participants who received cannabinoids and improved a clinically significant improvement. About 50% of the participants improved a clinically significant improvement following a cannabinoid treatment, and the blue stripes represent a participant who received placebo and improved a clinically significant improvement. And you can see that about 20% of the participants improved a clinically significant improvement in the behavioral assessment following a placebo treatment. For the core symptoms, the placebo effect was less prominent, but still about 10% of the participants, even more, improved a clinically significant improvement in their core symptoms of autism after being treated with placebo. So we of course knew that, that we will find a placebo effect in our study, but to know it and to see it, it's different things. And when we saw it in front of our eyes, it was quite shocking. And we decided to look into it and to see why some children respond so well to placebo while others not. So I say again, 50 participants were assigned to receive placebo in the first period and 50 in the second. Of those who completed the study, about half responded a clinically significant response to placebo in at least one of the 4 assessments, and about 20% responded a clinically significant response in at least 2 assessments, and these 20% were defined as placebo responders. And we tried to see which factors contribute or can predict the placebo response in our population. And we looked into demographic data, which means age, sex, level of function, the severity of core symptoms, also about the severity of the symptoms at baseline to see if this can explain the placebo effect. And also we have asked all the parents of the participants to complete a specific questionnaire that was developed specifically for this study and taps 8 domains that are known to influence the placebo response. In this questionnaire that we called experience and expectation checklist, there are 29 statements, and the parents should mark if he agrees, strongly agrees, somewhat agrees, or disagrees. And the 8 domains that are being tapped are parental expectations, child's ability to understand the purpose of the treatment, previous experience with similar treatments, which reflects behavioral conditioning, as I explained earlier, parental locus of control, the quality of the patient-physician relationships, relative aggravation of the symptoms at baseline, which reflects regression to the mean, fluctuation in symptom severity at baseline, and adherence to study medications. And these are the characteristics of our participants, those who received placebo and included in the study. The average age is 11 and a half years, 80% boys. The severity of the core symptoms was high according to the EDOS comparison score, 8.8 is really high. And the adaptive level was relatively low, 52 at average. And in terms of results, we didn't find any demographic factor that contribute to placebo response, not the age of the participants, not the sex, and not even the severity of the core symptoms or the adaptive level. We also didn't find that the baseline scores were related or predictive of a placebo response. So what do you think contributed most, or what did we find that contributed most to placebo effect in our population? If you have any guesses, I don't know. But yeah, we had the same guess as Gal just guessed, and we were sure that the parental expectations will be the most influential factor. After all, this was a study with cannabis, and you all know the hype about this treatment, and we were sure that the parental expectations will be the most influential factor for the placebo response, but we were wrong. Actually, parental expectations didn't contribute to a placebo response. The most influential factor was the child's ability to understand the purpose of the treatment. Another factor that was close to be statistically significant, was relative aggravation of symptoms at baseline, which reflects, not surprisingly, regression to the mean. You can see here that the y-axis represents the child's ability to understand the purpose of the treatment in a scale of 2 to 8. The higher scores represent higher ability to understand the treatment of the score, and the right column represent children who responded to placebo. And you can see that most of the children are high in their ability to understand the purpose of the treatment. The left column represents those who are non-responders, and most of them do not understand well the purpose of the treatment. Actually, each point in this 2 to 8 scale doubles the child's chances to respond to placebo. So if I want to conclude, in the clinical setting, we want to increase the efficacy of our treatments. And like it or not, the most safe and promising way to do that is to increase the placebo effect of the treatment. And in order to do that, we need the child to understand the purpose of the treatment, to understand that he is receiving a treatment that might help him. So we have to invest in that. And even if it looks like the child cannot understand or does not understand, we have to try and not just to talk to the parents above his head. On the other hand, in the research setup, we want to prove the difference between the treatments. And in order to do that, we might consider to include also children with low functioning ASD, children with low IQ, because most of the interventional studies today include children with high IQ over 70. So if we will include children with lower IQ who cannot understand the purpose of the treatment, it is predicted to reduce the placebo effect and to increase the likelihood of proving the treatment to be better. Also, it's very important, especially in clinical studies, but not only, to be very careful about the wording we use to describe the treatment. At least in clinical studies, we have to do that to minimize the variability in the placebo effect. And it's also advisable to examine the child's ability to understand the purpose of the treatment in real time when you just give him the treatment and not retrospectively. Thank you.